As men and their loved ones navigate their treatment options for prostate cancer, one option includes robotic-assisted laparoscopic prostatectomy. Robotics has significantly transformed the way we surgically are able to treat prostate cancer over the last 20 years. There are many advantages of using a robotic system for prostatectomy, including less blood loss, shorter hospital stays, less pain, and quicker recovery times. I'm excited to be teaming up with the Prostate Conditions Education Council and Intuitive Surgical to present to you today a webinar on robotic-assisted surgery and how it currently fits into the prostate cancer treatment landscape. I would like to thank the Prostate Conditions Education Council team for having me back to present another prostate cancer webinar for PCEC. It is always an honor as PCEC continues to be a national leader in increasing awareness and education on prostate cancer, current treatments, and men's health issues. PCEC is an amazing resource for men and those that care for them. I was excited to be tasked with giving a talk this year on robotic-assisted surgery and how it currently fits into the prostate cancer treatment landscape. My name is Dr. Garrett Pullman. I'm a board-certified urologist practicing in a private practice setting in Kearney, Nebraska. I'm also a host and founder of the Prostate Health Podcast, which is a podcast where I'm interviewing experts, innovators, and leaders in the field of urology. The goal is to better educate men and those who care for them regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions. For those needing to dive in even deeper, I also created the Prostate Health Academy, packed full of in-depth lessons, resources, and a private community forum for Academy members. So before we get started with the webinar, for those of you that have not visited the PCEC webpage, it is really a great resource to men and their loved ones. On the PCEC website, you will find numerous resources, including but not limited to easy-to-use health event and screening finder tool, where you can simply type in your location and find the nearest free prostate cancer screening and men's health testing events. There's excellent information no matter what stage you're at in your prostate cancer journey. They also have an excellent section on prostate cancer markers. And you can also view past webinar archives like the one today on the site as well. So the website is www.prostateconditions.org. Again, make sure to check it out. 1 in 8 men will be diagnosed with prostate cancer during his lifetime. With early detection, we are saving lives. Detecting prostate cancer at an early stage offers the best hope, with the 5-year survival rate at nearly 100%. Now that drops to 28% if it spreads to other parts of the body, which is why prostate cancer screening and early detection is so important. And we need to give a lot of credit here to PCEC, which has led the way in helping save lives by increasing awareness among the general public about the importance of early detection. Prostate cancer is even more common in African Americans. Not only do African American men have the highest incident rates in the world, they have the highest mortality rate. Receiving the diagnosis of prostate cancer can be very distressing for men and their loved ones. Where do you go from here? What are your options? While easier said than done, the first step is to take a deep breath and don't panic. If the prostate cancer is determined to be localized to your prostate, you may have several options depending on your risk stratification. Things like your PSA level, Gleason score, and number of cores positive for prostate cancer help determine your level of risk. Active surveillance is one option that involves monitoring the cancer closely. With active surveillance, the plan is still to initiate curative treatment if the cancer ultimately appears to be more aggressive. Looking at the National Comprehensive Cancer Network, or NCCN guidelines, active surveillance candidates include men with very low risk prostate cancer, men with low risk prostate cancer, assuming a low number of positive cores, as well as those with favorable intermediate risk prostate cancer. There's radiation therapy, which uses high energy rays or particles to treat prostate cancer. The 2 main types of radiation therapy for prostate cancer include external beam radiation therapy, where the radiation is beamed into the prostate, and brachytherapy, or internal radiation, where radioactive seeds or pellets are placed in the prostate and emit radiation over time. And then there is radical prostatectomy. This is surgery to remove the prostate gland, which is what we will be really focusing in on today in more detail. While there are various options available to address prostate cancer, many doctors and their patients choose radical prostatectomy. As a urologic surgeon, I work with many of these patients on their journey with prostate cancer. In the U.S., it is estimated that approximately 268,000 new cases of prostate cancer are diagnosed per year. And every year, approximately 89,000 men undergo a radical prostatectomy. So with the radical prostatectomy, again, this is surgery to remove the entire prostate gland and seminal vesicles. Seminal vesicles are a pair of glands which sit between the bladder and rectum and contribute fluid to make up a portion of a man's ejaculate or semen. During radical prostatectomy, it is often recommended by your urologist to sample some of the surrounding lymph nodes adjacent to the prostate, also known as a lymph node dissection. So who is a candidate for radical prostatectomy? First of all, one must be diagnosed initially with prostate cancer. I've had many men come to me and say, hey, can I just have my prostate removed so I don't have to worry about getting prostate cancer? Well, unfortunately, it's not that simple, as there can be several risks of radical prostate removal that we will get into in just a bit. So candidates for a radical prostatectomy are those with prostate cancer that is confined to the prostate. Typically those who still have good overall health and have an overall life expectancy of 5 to 10 years or more. There are several different techniques for radical prostatectomy, with the most common method currently the robotic-assisted laparoscopic prostatectomy. A study by Tawari et al. That reviewed more than 400 original research articles encompassing almost 287,000 surgeries, the largest compilation of radical prostatectomy patients to date. The study showed that robotic-assisted surgery demonstrated similar positive margin rates compared to open surgery. A number of other studies comparing robotic-assisted radical prostatectomies to open surgery and to laparoscopic surgery show similar positive surgical margin rates. Additionally, it evaluated perioperative and intraoperative outcomes. The review concluded that robotic-assisted radical prostatectomy shortened hospital stays, resulted in fewer transfusions, and fewer perioperative complications and reoperations compared to open and laparoscopic surgery. Total intraoperative complication rates and mortality rates were low for all surgical modalities, suggesting that radical prostatectomy is a safe procedure. It's important to note that individual patient outcomes may depend on a number of factors, including but not limited to patient characteristics, disease characteristics, and surgeon experience. The first documented use of a robotic-assisted surgical procedure occurred in 1985. This was the Puma 560 robotic surgical arm, which was used for a delicate neurosurgical biopsy, a non-laparoscopic surgery. This then led to the first laparoscopic procedure involving a robotic system, cholecystectomy or gallbladder removal in 1987. The following year, the same Puma system was used to perform a transurethral resection of the prostate, or TURP, for benign prostatic hyperplasia, or BPH. In 1990, the ASOP system produced by Computer Motion became the first system approved by the FDA for its endoscopic surgical procedure. In 2000, the Da Vinci surgical system was the first robotic system approved by the FDA for laparoscopic surgery, and was an all-encompassing system of surgical instruments and camera with a 3D magnification screen, which allows the surgeon to view the operative area with the clarity of high resolution. The 1 centimeter in diameter surgical arms represented a significant advancement in robotic surgery from the earlier large-armed systems. The endo-wrist features of the operating arms precisely replicate the skilled motions of the surgeon at the controls, improving accuracy in small operating spaces. The Da Vinci surgical system consists of three major components. The console is where I sit and control the instruments while viewing the patient's anatomy with high-definition 3D. The patient side cart, positioned next to the patient, holds the camera and instruments that I control from the console, and the vision cart enables communication between the components and supports the 3D high-definition system. The initial Da Vinci robotic model only had 3 robotic arms, one arm utilized for the camera and the other 2 to use for instruments. Over the last 20 years, there have been a series of newer generations released, all of which have 4 robotic arms. I've personally performed surgery on 4 different generations of Da Vinci models. I feel that adding the 4th arm was a nice improvement. Now, being able to use the 4th arm to help retract while the other 2 arms act as the surgeon's hands. There's also a dual console version, which has been widely adopted at many training institutions. With traditional robotic surgery, one of the surgeons is seated at the console while the other surgeon is at the bedside. Verbal communication takes place, but if a demonstration at the console is warranted, as new surgeons are learning, the surgeons would need to temporarily halt the procedure and change places. With the dual console system, sitting side by side, the surgeons can control the robotic arms with the touch of a button. Many of the new versions are also equipped with virtual simulator software, which is helping minimize the steep learning curve associated with many of the complex procedures performed robotically. While I was in training, we also set up multiple skills labs that were put on where we could practice basic tasks such as moving objects and suturing using the robotic system. So again, the most common surgical method being utilized for radical prostatectomy is robotic prostatectomy. This involves 5 to 6 small incisions which are made in the mid to lower abdomen. A camera, also called a laparoscope, gives a magnified high-definition 3-dimensional view for the surgeon. As I'd mentioned before, the surgeon sits at a console and uses precise, tiny instruments which are attached to a computer-assisted mechanical device, the Da Vinci robotic platform, to perform the surgery. When counseling patients, I often explain that I'm not just hooking you up to the robot, then heading off for coffee. As the surgeon, I'm actually controlling the instruments and performing the surgery, but using the robotic platform to help assist me in performing the surgery. Some of the advantages of robotic prostatectomy over the traditional open approach include less pain, less blood loss, as well as quicker recovery time. There's not typically any major difference in cancer control, urinary control rates, and sexual function outcomes comparing the robotic to the open surgical approach. As far as what to expect, the typical hospital stay is usually one overnight stay, with most men going home the following day after surgery. Your surgeon may have particular requirements that must be met before being discharged from the hospital. For me, prior to discharge, I usually prefer that your pain is well controlled, tolerating diet, walking around, the catheter is draining well, and that you're passing gas. But I typically don't require a bowel movement prior to discharge home. If all these criteria are met, there's a pretty high probability that once you go home, you're going to stay home and not have to come back to the emergency room shortly after discharge. A urinary catheter is placed in surgery while you're under anesthesia. The catheter drains urine from the bladder to a drainage bag. This catheter is typically removed in 7 to 10 days at the clinic during your first postoperative visit. As far as lifting restrictions, typically there's no heavy lifting advised during the first 4 weeks after surgery. We encourage early walking immediately after surgery, which can also help wake up the bowels following the procedure. A pelvic lymph node dissection may also be recommended to remove lymph nodes in your pelvis at the time of prostate removal. Based on NCCN guidelines, it is recommended if there is greater than or equal to a 2% probability of lymph node involvement with cancer to perform the lymph node dissection. Some of the risks of a pelvic lymph node dissection include cyst formation containing lymph fluid, also known as a lymphocele, as well as possible injury to nearby blood vessels and nerves, such as the obturator nerve, which is responsible for some leg movements as well as sensation. There are two potential side effects many men are concerned about with radical prostatectomy that can affect quality of life. The first is urinary control issues or urinary incontinence, and the second is erectile dysfunction or having difficulty obtaining erections following surgery. Some of the other risks of radical prostatectomy may include, but not necessarily limited to, bleeding, infection, injury to nearby organs or structures, and scar tissue formation at the urethra and bladder. When counseling men and their loved ones about urinary control after prostatectomy, most men will see ongoing continued improvement during the first 3 months after surgery, but this may continue to improve even up to 1 year after surgery. This progression may vary, but most men will have to wear several pads per day for urine leakage, and some men will get down to minimal leakage as quickly as 2 to 4 weeks out from surgery. The overall success rate, defined as getting down to 0 to 1 pads per day, is 86 to 97% at 1 year out from surgery. Now, as we approach the end of our webinar today, I wanted to conclude with a few slides regarding sexual function. There are nerve bundles on both sides of the prostate, which are needed for natural erections. These nerves are essentially stuck to the prostate capsule. Some men are candidates for a nerve-sparing prostatectomy, including men who are still able to have erections prior to surgery and desire to maintain or at some point regain this function, and if there is no cancer suspected beyond the margin of the prostate. With a nerve-sparing prostatectomy, it is designed to protect and preserve the network of blood vessels and nerves. In some cases, the urologist is able to spare nerves on both sides of the prostate. In others, the tumor may be too close to one set of nerves that they have to sacrifice the nerves in that area to make sure they get all the cancer out. Men who undergo a nerve-sparing prostatectomy are more likely to recover their erectile function, but there are no guarantees. Younger men are typically more likely to have recovery of sexual function compared to older men or men that are already having difficulty with erectile dysfunction going into surgery. This recovery may range anywhere from 3 to 36 months. The overall reported success rate in recovery ranges anywhere from 30 to 70%. And higher success is reported when both nerve bundles are saved, also called bilateral nerve sparing. One option to potentially help speed up the recovery process is utilizing a penile rehabilitation program. This may involve starting an ED medication such as daily Cialis at 5 milligrams starting 2 weeks prior to surgery. Citrulline also has been used in conjunction with the ED medication prior to surgery, which is a naturally occurring amino acid. After surgery, the same regimen is continued. In addition to the oral medications, if not getting erections yet, a vacuum erection device or a VED can be used starting 1 month after surgery to help start getting blood flow into the penis. Penile injections, also called intracavernosal injection, can be utilized especially for those still having issues if no success with pills and the VED. One of the more common injections used is called Trimix, which is a mixture of 3 drugs, phentolamine, papaverine, and alprostadil, and the urologist will typically teach the patient initially in how to perform the injection. Then the patient can ultimately start performing these injections at home as needed prior to intercourse. Now that concludes our webinar today on the role of robotic-assisted surgery in your prostate cancer journey. I would welcome you all to check out the Prostate Health Podcast. We really have had an all-star cast of guests so far, with many episodes which would be applicable to many of the PCEC followers. To make sure you don't miss an episode, you can subscribe to the show through the podcast app on your iPhone or Android device. We're also on Spotify and pretty much most outlets that host podcasts. You can also find episodes at theprostatehealthpodcast.com. There's also a link on the PCEC website. And lastly, I'm excited to announce that the Prostate Health Academy has just recently launched. The Academy has multiple features, including bonus content from the Prostate Health Podcast. A critical component of the Academy is providing a private community forum moderated by myself where you can connect with like-minded individuals within the group. There are also comprehensive lessons covering information on prostate cancer, BPH, and prostatitis. I've also included essential information on prostate, diet, and exercise. Those interested can simply sign up at prostatehealthacademy.com to sign up and begin taking advantage of the Academy. So I appreciate your attention. I know that was a lot to pack in. I want to again thank the team at the Prostate Conditions Education Council for inviting me on today to speak. If you're active on social media, make sure to like and follow PCEC on both Facebook and Twitter to stay up on the latest from PCEC.